Okay then, and let's begin it. Okay, so you see, are we recording the lecture? Yes. Okay. So now where we left is, these are little problems that happens when there are more participants. There is a limit of 30 minutes, and definitely I'll overcome it later on. But for now, sorry for that distortion. Okay, now, but when I'm talking about this, so we were like kind of studying regarding this. I was telling you that it increases the GI motility, okay? And there is a terminology which is called megacolon, okay? So what does it do in megacolon? There is a ganglion, okay? That portion of ganglion is distorted, okay, at the level of colon, okay, and then the colon does not cause that contractive efforts. It does not show that. So because of that, when it will not show those contractive efforts, the patient might undergo, in no gastric motility. So when the patient will have no gastric motility, the stomach will rise, the patient will have pain, so all those things will happen. The patient will have stomach or intestinal gases, so all these things. So there is another function of this Botanical as an increasing gastric motility, therapeutic use in megacolon. So these are some little things which you kind of need to remember. Okay, also we use this drug in a thing called gastroparesis. Okay, gastroparesis. So while listening these lectures, you can like make your own notes. So I will like kind of review the therapeutic uses once again. So it's like gastroparesis is basically atonic stomach. Just as we have an atonic bladder, we also have an atonic stomach. The nerves to this stomach is kind of not working. And what is the nerve we have? We have this vagus for parasympathetic, okay, and the the sympathetic branches. So you see this, there are so many therapeutic applications apart from urinary retention. So you should kind of know that it stimulates the chronic atonic bladder, okay, and also the atonic stomach, which we call gastroparesis, the megacolon, or the atony of the bladder because of nerve distortions and neurogenic atony, or you can use it in the postpartum urinary retention or non-obstructive urinary retention. So these all can be the reasons for this kind of thing. So there are terminologies which are called as Hirschsprung disease in children. That is another name for this megacolon. So you kind of write it down in your notes as well, that Hirschsprung disease and megacolon are the same. Okay, that we call it as aganglionic colon. The ganglion is not present over there at those regions. Similarly, gastroparesis is also known as paralytic ileus. So while working in a surgery unit, these are the things that can be asked, and they can ask you that which drug we can give in such conditions. So your answer would be Botanical. Okay. Now, there are always some contraindications which are not given in this book, but I want to kind of like tell you the contraindications at this particular level. So what will be the contraindications of this drug, Botanical? We are still on Botanical, okay? So the contraindications will be, because it increases the gastric motility. So if the patient has peptic or duodenal ulcer, you will not give this drug, okay? Because it will exacerbate, or it will increase the production of gastric acid, that is hydrochloric acid, HCl. Okay, so if the production of gastric acid or hydrochloric acid is increased a lot, it will irritate that mucosal lining. What is an ulcer? What is an ulcer? A breach in the mucosal lining. Okay, a breach in the mucosal lining is ulcer. So both gastric and duodenal. ulcer, we will not give this drug. Okay, Botanical. Okay, what will be, this is one contraindication. Okay, what will be another contraindication? The another contraindication will be number 2 is is heart disease. Okay, is heart disease, because if it is working on uh, the M receptors, it should not be given in, although its function is more on M3. Okay, and a heart has M2. Okay, our heart has M2, but our heart has M2, but in patients like COPD, like in patients like ischemic heart disease, okay, you will not give this drug. So ischemic heart disease, for that, the M2 receptors are responsible, but it can show some effect on M2 as well. But in COPD, you will like not at all take a risk. You will not at all take a risk if the patient has COPD, because is COPD and also asthma. Okay, also asthma. So you will not give this drug in patients of COPD and asthma. Do not give this drug. Do not. These are big contraindications. Okay, just never ever give these drugs to these two patients. What is the reason? Because these are obstructive lung diseases. The bronchioles of the patient are you already so obstructed and narrow, there is no passage of air to pass freely, and they are having difficulty in breathing. So if you will give this drug Botanical to them, it will cause bronchoconstriction more, and the patient will die. They will die. Okay, the patient will die. Finish. So these are the contraindications. Okay, then okay, some other contraindications of this drug are um, hyperthyroidism. Okay, so I was kind of, I remember these contraindications by side effects, by their actions. You know how, like I will tell you. Wait a minute. Hyperthyroidism. In hyperthyroidism, there is excessive sweating. Okay, excessive sweating. So you will not give this drug in a patient who has hyperthyroidism. Okay, so there are certain contraindications. You have to remember them, and they are very important. I will kind of make this thing more more to you. Wait a second, let me, I wanna share a whiteboard. Okay, so we will kind of make a summary for botanical. We will kind of make a summary for botanical therapeutic. Okay, therapeutic uses. Okay, and what are they? What are the therapeutic uses of Botanical? So the number one therapeutic use is urinary retention. Okay, it can be because of postpartum. Okay, it can be because of postpartum. It can be because of a neurogenic atony. Okay, it can be because of non-obstructive urinary retention. Okay, it can be because of all these things. So you should kind of know and understand these things. Hmm, then number two is um, in gastroparesis. Okay, gastroparesis. What is gastroparesis? It is atonic stomach. Okay, or you can say paralytic ileus. Okay, or you can say hair-sprung disease in children. Hair-sprung disease or to- toxic megacolon. Okay, so these are the therapeutic uses of Botanical. These are the therapeutic uses of Botanical. Okay, now if I have to talk about the contraindications, the contraindications will be peptic ulcer. Okay, it will be COPD, it will be IHD, it will be hyperthyroidism. Okay, so remember these things. Also, we will not give it in BPH, that is benign prostatic hyperplasia. Why we will not give in benign hyperplasic hyperplasia, benign prostatic hyperplasia? Because in benign prostatic hyperplasia, the prostate is so enlarged. Let me just draw it. So in this is the male urethra. This is the male urethra, and this is the prostate gland. Okay, so the part of urethra, this prostate gland is so enlarged that it compresses this urethra. So there is already, this urethra is already too narrowed that there is no space. Okay, there is no space in over here. So you see, because there is no space in over here, the urine cannot flow. So the bladder up will be full. And if you will give this drug, Botanical, to this patient, it will contract the bladder. The brain will have the signals that the patient needs to micturate, and it is already blocked. So the patient will feel pain, lot of pain. It is a painful condition then. Okay, so never ever give this drug to BPH patients as well. Clear? So these are the contraindications, and the adverse effect I will not write down because you all know the adverse effects, that they are the same as actions. Another thing that I want to write down here is, which you should know, is the antidote of this drug. If someone take this drug a lot, too much in quantity, the antidote is atropine sulfate. Okay, and this is important because it is asked in MCQ, so I will put in sterics here. So okay, so you have to remember this. The antidote for acetylcholine, or the antidote for all the cholinergic agonist drugs, are atropine sulfate, because it is a cholinergic antagonist. Okay, so let's move to, I will clear all these drawings. You can take a screenshot of it as well. Okay, I will stop share and I will share again my book with you. So yes, let's come back. We are back to the back to this portion of now we are done with this drug. Okay, we are done with Botanical. The next drug we are studying is carbachol. Now carbachol, this drug is you can remember this drug with C and B. Sorry, B and C. Okay. The mnemonic is B and C. So for B, it is bowel, GI, and for C, it is cardiovascular system. But it also works on I. See, like you can make it BCE, or you can make ABC and A for I. You know, just make any mnemonic if you want to. Like it's not like any hard and fast rule. But I just want to tell you that this carbachol works on both muscarinic and nicotinic receptors. Now, for instance, this receptor can be muscarinic or nicotinic if the drug at this particular level is carbachol. Okay, so carbachol works for muscarinic and nicotinic receptors both. I will only teach you carbachol because the lecture will go too long then. We will study methacholine. There's not too much about methacholine, but there is much about pilocarpine. It's a very important drug. But I'll teach you only carbachol for today, and we will end this class. Okay? So don't feel the lecture is going too long. So carbachol works on both muscarinic and nicotinic receptors. Okay, but the action is like fluctuating, so we kind of say that carbachol is a biphasic drug. Okay, so it sometimes show its action in muscarinic and sometimes on nicotinic, but on the nicotinic portion, it does not uh, show like it lots of, okay, like kind of if it activates the nicotinic receptors, like how can I say, if it activates the nicotinic receptors, the depolarization is for a long time. Okay, and the depolarization is for a long time, and then there is that slow repolarization. So the depolarization is for a long time when we talk about the uh, nicotinic activation by this drug carbachol, and the repolarization is very prolonged and it's very slow. So this is one thing that I want to tell you. Then we have this action on it, that it you see, it's written carbon copy of acetylcholine. It's just to remember, and it is also resistant to acetylcholine esterase as Botanical. So that is why these drugs are called direct agonist drugs. Why? Because when they are like attached in over here, when this acetylcholine comes really happily to destroy it, it cannot, because there is a protective barrier. Okay, because this drug has this this shield activity to protect itself on its own, so I can't do that. Then the applications are, it constricts pupil and relieves intraocular pressure in open angle glaucoma. This is very important because the this drug is given in not in emergency conditions, but this drug is given if we want to decrease the intraocular pressure so soon. So it decreases the intraocular pressure in like, so this is somewhat I'm telling you clinically, in 10 to 20 minutes. Okay, the the best drug to decrease intraocular pressure that is given in emergency is pilocarpine. It's not carbachol. But I'm just telling you the time so that you may never mix it. In like 10 to 20 minutes, you can relieve the intraocular pressure by this drug. And the pupil remain contracted for like about 4 to 8 hours. 4 to 8 hours. So the pupil can remain constricted for like about 4 to 8 hours. So this is the this action, and important action. So what is open angle glaucoma? If anyone has the concept of open angle glaucoma, open angle glaucoma is when the trabecular meshwork is not blocked. Okay, let me show you a picture of open angle glaucoma. Wait a second. Open angle glaucoma. So open angle glaucoma, I just wanna show you the difference between open angle and closed angle glaucoma. This is a very good picture. So resume share. Okay. So you see this is open versus closed angle glaucoma. So this is trabecular meshwork. So in open angle glaucoma, this angle of lens and cornea is wide more, but in closed angle it is short, because the angle that is formed from here to here, this angle, okay, this angle is narrow and this angle is wide. This is a wide angle. So this angle is blocked by this muscle, okay, muscles of iris, and this trabecular meshwork is blocked, so uh, the aqueous humor cannot flow in here. Okay, the aqueous humor present at this area cannot flow in from here. This region is also called Sclem's canal. So the trabecular meshwork in the Sclem's canal is opened in the open angle glaucoma. Okay, it is open, so it is not that hard or is that difficult. But close angle glaucoma is very crucial because it is blocked. Okay, but the humor cannot flow in like so easily. So that is why it's like open angle glaucoma, and the patient builds in pressure at the vitreous humor also because of it, and there is a pressure on the eyeball causing damage to the optic nerve which is present at the back. The optic nerve which is present at this particular area, it will cause pressure, so the intraocular pressure of the eye will increase. Okay, intraocular pressure of the eye will increase. So let's go back to the book. So you see this in carbachol, so this open angle glaucoma. So one more thing, like the normal intraocular pressure of the eye is like 18 to 21 millimeter of mercury. So you have to kind of remember this, so that in patients, if you're like kind of get a chance to work in ophthalma, so you should know that, or you're a medicine doctor, and your patient has some problems, and you consult an ophthalmologist, and in the report it's written like 25. So you should know that it is above normal. Okay, so this is normal. This is normal intraocular IOP, intraocular pressure, is 18 to 21. So in open angle glaucoma, it rises. So in order to release this pressure, we give this carbachol. Okay, so remember, open angle word with carbachol. Okay, so acha, this is the thing that I want to tell you, and I've also explained you the process. So it also, cause meiosis. So the process of meiosis is this picture. This in this picture, I will tell you the process of meiosis is. Mm, let me tell you the process of meiosis in this picture. So in this picture, I will tell you the process of meiosis as well. So you see, this is the ciliary. This is the ciliary body. Okay, the ciliary body contracts. The ciliary body causes contraction. The ciliary body contracts. Okay, when the ciliary body contracts, you see this iris. This iris will move away from this cornea. This cornea. Okay, the iris will move away from cornea. The ciliary body will contract, and the iris will be like this. Okay, so it will this is iris now. After contraction, this is the iris. So it will move away from this cornea. Okay, and then the iris, the both of the iris, they come closer to each other. Now, for example, this is the eye. Okay, now this is the eye and this is the iris. So both of this, wait a second, let me draw it again to show you. For example, or let's change the picture. Let's take this picture. Okay, this is a very good picture now. Now you see, this is the ciliary body. This is the ciliary body, and this is the iris, and this is the cornea. Okay, this is the cornea. Okay, this whole lining. This whole lining is the trabecular meshwork. Okay, this is the cornea, this thing, cornea. Over here at this region, aqueous humor stores. This is your lens, okay? And then this if I draw this little thing like this is your pupil, okay? So this is how it works. So and then above this there will be that white covering of the eye, that will be sclera. So I'm telling you the whole eye anatomy now. So this is ciliary body and this is iris. So you see, when this, now I'm removing all these labelings, okay? You understand? Now when the ciliary body will contract, this will be like this, and this iris will be like this. So they will come closer. So when they will come closer, you see, now this big circle initially is this small. So this is how meiosis occurs, that is, the pupil is constricting. It will constrict the pupil. So this is the mechanism of this is the mechanism of the constriction of pupil, that is what we call meiosis. So these points are really important to remember and to learn. Now because we have this little time now, so I just want to touch the methacholine, because there's only one line that you need to remember in case of methacholine, that in actions it stimulates the muscarinic receptors in airway when inhaled. So basically they are talking about M3 receptors because they are present in the airways, okay, in the bronchus and bronchioles. And what it do is, it is a challenge test for diagnostic of a challenge test for the diagnosis of asthma. So this is very important to remember, that methacholine works on M3, okay, and it is used as a challenge test for diagnosis of asthma. When you will be studying respiratory system too much, then you will be getting my point, why I told you this, because there are so many other drugs that you will be studying and they will cause problems, real problems. So methacholine, just remember, this is a challenge test for the diagnosis of asthma. Okay, and what will it do? It will constrict the blood vessels. It will not open, it will constrict. Okay. In asthma, the blood vessels are already constricted. So, in a normal patient, when you give methacholine, it does not constrict the blood vessels to a life threatening effect. But when you give this drug to an asthma patient who has already obstructed bronchioles, then it will cause serious problems in inhalation, and then you'll find that, okay, this patient really has asthma. Okay, so for tomorrow, we will start our lecture from pilocarpine. Okay, pilocarpine, and then we will move to the indirect agonist. Okay, the acetylcholine esterases that destroys or blocks this enzyme and then works. Okay, by increasing acetylcholine. So we will be studying these four drugs along with pilocarpine tomorrow. So this is all about today's lecture, and inshallah the next class will be of biochemistry or anatomy. I will inform you. It will be at 7 p.m. sharp. Okay, so take care everybody. So this PDF which I used is of neurophysiology again. So this is only one PDF which I'm using in so many things, because this all is interconnected. Okay, so that is why. So let's so I'll see you people tomorrow, or like at 7 p.m. but for pharmacology tomorrow. Okay.